Good evening, everyone, and welcome to tonight's webinar on lasers hosted by the YDC. For those who don't know much about the YDC is essentially young dentists in South Africa. It's a council that's formed by SADA, where we try and tackle some of the issues as well as try and help young dentists as they come into the working world. So just have a couple of house rules tonight. Please refrain from using the raise hand function. Rather type your comments or questions in the Q&A tab. There will be CPD points awarded for tonight. There'll be one CEU appointed. The certificates will be loaded to the HPCSA and SADA platform, and you'll be able to access it under your member profile. So tonight we are going to be talking a little bit about lasers with one of the very well-known dentist in South Africa, Bryan Sher. So just a little bit about Bryan. Welcome, Bryan. Bryan always wanted to be a dentist. Even as a child, he thought about being a dentist someday. He enjoys working with people and being able to help them. He loves the psychology of what makes people tick and manipulating them into having a pleasant experience in the clinic. He also enjoys challenges and learning and is constantly attending lectures and likes to stay up to date with the latest technology. Amongst the many, many things he has done, some of the cool things that I think stand out is not only has he done implant courses, is an intermediate paramedic, has advanced cardiac life support training. He also completed his mastership in laser dentistry in, I'm not going to butcher the name, in the university in 2017, as well as completing his master's in Germany in 2019. He loves scuba diving. He has climbed Kilimanjaro. And before we were just chatting about he's doing the Cape Epic. So he's also not only a dentist, but also a very active person and takes care of his health. He's also got a few international lecturing exposure in Sweden, Switzerland, Denmark, Nairobi. So without further ado, Bryan, please welcome and thank you.
Hi, guys. Thank you very much. And thank you for inviting me. And it's a great privilege to actually speak to the young dentists. Let me just see if I can share my screen. You can just confirm whether you can see that now.
Yeah, you're good.
Am I good? All righty. Well, yeah, once again, thank you very much. And I'm just going to widen that a little bit so I can see what's going on. There we go. All right. So I've been involved with lasers for 2016. And I first started with a mastership course here in Cape Town. And I just got hooked by it. And it became more and more interesting, and I ended up doing that MSc. But I find that I use my laser every single day in practice. Today, for instance, before I get going today, I did two, I don't really use cord much. I did two troughing with my lasers, nice big juicy gums, a little bit of a crown lengthening on the one, and ended up with no bleeding, could take a scan easily. I think that's one of the bigger problems with scanning is getting that border nice. Today I did some PBM, photo biomodulation. We'll touch on that a bit later. Just thinking that's about it for today. Tomorrow I've got lined up another crown lengthening and some other little things. So I use it every day. I've got two lasers, an erbium laser and a diode laser. I'll explain the difference in a minute. But what is laser? I'm not going to go into the whole big physics and how the laser works, and I sometimes do that in these lectures, but it's not really important to how it works. You just want to know that a laser light's coming out the end of the fiber and it's going to do something. The characteristics of a laser are very unique, which makes it what it is. So it's a light amplification by stimulated emission of radiation. So we end up, the lasers are used obviously in dentistry. in LASIK surgery, in weaponizing, in laser cutting, in industry, CDs. So we use lasers everywhere in our lives. The characteristics of lasers are, firstly, that it's a monochromatic light. If you take a normal white light, it splits up into the different colors. A laser is just one color, in inverted commas. You might not be able to see it, but it is, if you consider, just one wavelength. So you can just think of it as a color. So maybe you can't see it, but a laser is just one color and no other. The second characteristic is that it is collimated. And as the word describes, it's in columns. So that doesn't spread out. It's not diffuse. It doesn't, like your light bulb in your room, just lights up the whole light. A laser is one directional. It's all collimated into a tiny focused area. The third one is that it's coherent. And that means that we have an electromagnetic wave, and that wave, they're all synchronized. So you can imagine being on the beach and a wave comes in and then it goes out again. And as it backwashes, where two waves meet exactly on the crests, you end up having this massive wave that knocks you off your feet. But if a wave is the opposite, out of phase, there'll be a flat area there. So this is what gives lasers its kind of strength or power, is this whole, everybody working together in the same phase. Okay, so that's very basic what a laser is. It's characteristic by it's just one wavelength of light. That's the kind of the take home here. The fact that we can't see them is that we are, sorry, I'm glancing, I've got a spare screen if I'm looking to the side here. You can see this is where we can read. This is our visual reference, where we can actually see light from violet all the way to red. So ultraviolet, we can't see. Those are starting to become harmful radiation. So you can see that's ionizing radiation. So people often ask me, oh, is laser not dangerous? It's not dangerous because it's a non-ionizing radiation. So X-rays, gamma rays, UV are ionizing radiation. It means they can have a direct effect on the nucleus of a cell. Laser cannot have a direct effect. It does have indirect effects, which we can get onto that a bit later. The lasers that we use mainly in clinical dentistry are the reds, and then the diode lasers and the erbium lasers. Now, these are different wavelengths in nanometers. So we use the diode laser. The one I use is the EPIC, and that's a 940 nanometer. It's just one wavelength of light, that's only one. And that's 940 nanometers. We can't see it. So in fact, it's the same wavelength that your remote control on your TV uses. It's also 940, but that one is just an LED, a light emitting diode. It's not collimated and it's not in phase. So it just changes your TV because you can aim it anywhere really and it'll change the channel. So a laser is a whole lot of those, but focused into one area. The erbium is 2790. That's way up in the spectrum. So, but you can't see these. And to enable us to target a tissue is we use a red laser. So all lasers actually have two lasers in them. One is a laser pointer, which is pretty harmless, which you see that's your aiming light, much like a guy with a rifle. He's got a laser pointer and he can see where the bullet's going to go. Once he fires the bullet, you can't see the bullet. And that's much the same as the 940, the infrared lasers. You can't see them, but your aiming beam is the one that helps you. So what do they do? Once we've fired a laser, we got our laser, what do they do? There's a tissue interaction. There are basically four things that can happen. One, it can reflect. So that's probably a bit more of a hazard. We don't really want it to affect. That's off rubber dam clips, or if your mirror handles, instruments. We don't really want reflection because lasers, especially diode lasers, can be detrimental to the eye. It's a laser safety hazard. So we all wear goggles. Everybody in the room wears goggles. The door is closed. And we got to be especially careful, especially with a diode laser, because it has a long range of effect. The erbium lasers only have a 4.5 centimeter hazardous effect. So they're not so bad, but you still wear glasses every time. So reflection is more like a hazard. Then we have transmission. This is what we want to happen if we're using the laser for photobiomodulation or low-level laser therapy. So we want penetration, we want transmission through tissues to get to a target tissue. Then we have diffusion, which is kind of partially absorbed. It bounces around a tissue and it just goes all over the place. Hopefully at the target tissue, we can get that happening. And then absorption. This is where the laser comes into surgery, to cutting things. We want it to be absorbed by the tissue to effect some kind of change. So that's the erbium laser and the diode laser. We want to get absorption onto the specific tissue. You can see that the different wavelengths, near infrared, red, green, blue, that penetration that I was talking about, the wavelength, that this 940, you get a far deeper penetration. There are lots of lasers on the market, and some of them say you don't even have to touch the tissue. You can just hold it away and it'll cut. This is true, but the penetration is very little. It's so highly absorbed that all the laser energy is absorbed there. It's not always a good thing because you get a lot of heat buildup. So now I'm going to take the two main lasers that we use, the erbium laser and the diode laser. Each laser wavelength has an affinity for a specific tissue. So, for instance, if you have UV, you put on UV, ultraviolet wavelength has a specific effect on your melanin, on the protein in your tissues, and it can be damaging. So each specific wavelength has a specific chromophore, we call it, or a photoreceptor that it interacts with. An erbium laser loves water. It adores water. Its first affinity is to water. In fact, it's so highly absorbed in water, there's very little penetration. And we use this to our benefit when we cleaning out root canal, when we cutting tissue, because 70% of our bodies is water. So that's a great chromophore. We can attack water very easily, highly absorbed. All that energy is straight away absorbed, and it ablates the water. It vaporizes the water. And that vaporization of water, whether it's in tissue or in hard tissue, in dentine, enamel, or caries dentine, it vaporizes the water. And that's what causes the cutting action. A diode laser, on the other hand, loves anything pigmented. So blood, hemoglobin, oxyhemoglobin, melanin. So anything that has a pigment in it is absorbed by a diode laser. Especially, what has bacteria got? When we're getting back to endo, bacteria are mostly pigmented and also full of water. So when we're using dual wavelength lasers in endo, we are targeting bacteria in two different ways. We'll get to that. All right. So how do we administer a laser? So 2 more slides on physics, then we can get to the nitty-gritty. The one, it's like taking a medicine. So you can choose what you're going to use for depending on what you want to do. So you can choose a laser depending on what tissue you want to interact with. I can't use a diode laser on teeth because there's no target for it. The first target it will see is the pulp. And we don't really use that on hard tissue. But an erbium laser can be used on teeth because it targets water. And we have various concentrations of water in teeth. So it's kind of like choosing between Panado and aspirin. If you take an aspirin, it's absorbed diffusely through the body. If you take a Panado, it's mainly absorbed in the central nervous system. So we're going to choose which medication we're going to have for what we're going to do. Also, the powers of them vary. So if I want to cut tissue quickly, it's like giving a script for I want 1,000 milligrams BD, or I want to take 250 milligrams QID. So 4 times a day. So we can decide what we're going to use. We can adjust the lasers according to what we want to do. Right. The last thing is if you're using a diode laser, there are 2 modes we can use it, the tips in. So the one is uninitiated. In other words, all the energy that comes from the laser goes through the tip and it gets straight transmitted into the tissue. So there's a big difference between the two, initiated and uninitiated. So if we're going to do healing, if we want to do ulcers, or we want to do PBM, photobiomodulation, or laser bacterial reduction in pockets, we're going to use an uninitiated tip. We want all the energy to penetrate deep down into the pockets or deep down into the target area where there's pain or for healing. The other option is an uninitiated tip where we using a cork or a bit of carbon, or you get these pre-initiated tips that those tips block the energy that's coming out. So it can't flow out the tip that easily, and it kind of gets caught up in a bottleneck at the tip. And this causes a hot tip effect. And that's what we use for cutting tissue. So initiated and uninitiated. All right, so let me have a sip of water. Thank you. All right, let's talk about a little bit of perio. I'm not a periodontist, and I kind of put a disclaimer on as well, is that having a laser doesn't make you a periodontist. It doesn't make you an endodontist. It doesn't make you anything except a guy who's using a laser. The same as your turbine. If you got a turbine, it doesn't make you a prosthodontist. It just makes you a general dentist using a turbine. And it's just an instrument that we use in everyday practice. In the beginning, when I started, I used to put in this, hold this memo to the patient, get consent to use a laser on them. And now it's just part of the practice. It's what I do. I use CBCT and I use lasers, et cetera, et cetera. So you don't actually have to ask special permission to use these things. All right, perio. So I'm not a periodontist, but I do quite a bit of this in the practice, and beforehand, the important part here is that you have to have buy-in from the patient. You can do whatever you like. If the patient doesn't have good oral hygiene, I think you're wasting your time. And I think that goes for any perio procedure. So if we got pockets, what are our options? We can give some antibiotics, but that's now becoming more and more resistant, antibiotics. And we're trying not to enhance the resistance of antibiotics. There are very few left that don't have resistance. The interesting thing is that a laser is not specific. So it's basically a broad spectrum antibiotic because it targets water and pigmented areas. It doesn't matter what the makeup of that bacteria is. So it's kind of like a blanket antibiotic if you're using laser. For also options, you can have systemic effects of perio that are huge, that have a major impact on patients. They found the same bugs in the brains of Alzheimer's patients that are unique normally to the oral cavity. What is option 2? We can, with or without laser, we can open a flap. And I think that we have big problems with that as well. So you get better vision, you can see what's going on. The healing is not so great. It's painful, and anybody who's had an open flap perio procedure, that's kind of the thing you do once, from what I've heard. It's very uncomfortable, and to reduce the pocket, we normally have to cut off something. To reduce the pocket, you end up with necks and sensitivity and recession. Then we have closed flap. Without a laser, we used I think the perios are opting before surgery, before opening a flap, is to do to do root planings, to clean out those pockets, get rid of the bugs as much as possible, and to see how that reacts. And then, if necessary, go in afterwards. But I think the first line of attack would be to do a root planning. Or you can do a closed flap with laser. And that is called the LANAP. And that's a laser-assisted new attachment protocol. And the key there is new attachment protocol. So, or laser-assisted regeneration. So there's no cutting. We don't cut open any gums. There's no sutures, because you're not opening a flap. And you do get true periodontal regeneration. First of all, from the bone, there's a substance called alkaline phosphatase. I'm not a biophysicist, but alkaline phosphatase inhibits, it breaks up the guy. It's actually a pyrophosphate that actually inhibits mineralization in bone. And it also releases, when it does that, it releases phosphates so that you can get the synthesis of hydroxyapatite. So that's what laser stimulates, this alkaline phosphatase. And then in the periodontal ligament, we get connective tissue. It's kind of like a race as to who's going to get there first. The gingival epithelium, which that is, I'll talk about that now. The connective tissue, the alveolar bone, or periodontal ligament. Who's going to get to that pocket first once you've cleaned it out? Probably the fastest grower, which will be the epithelium, because it grows 1 millimeter every 2 days. And fibroblast connective tissue will grow back 1 millimeter every 10 days. So part of the procedure is to actually inhibit the outer epithelial layer, and we kind of degranulate that and de-epithelialize rather, and that inhibits it to grow down into the pocket. Part of the action is a bactericidal action and irrigation with the lasers. We put that down there. We know that the erbium laser is bactericidal because it loves water. Bacteria contain water. And the reason how it does that is it vaporizes the water molecules. So when you vaporize a water molecule, it expands, I think it's like 1,400 times its own size, and then collapses again. And that action of this, it's like a cavitation action, actually cleans the surfaces. That's what cleans the smear layer out of in the root canal. But that stuff will clean your cementum layer. It kills all the bacteria, and it removes also granulation tissue and helps loosen deposits. I don't think a laser is great for moving thick calculus underneath a gingiva in a pocket. I think you need to do some scaling and root planning with that in between. So there's a whole process to it. I'm not going to go into detail with that. Suffice is to know that we modify the root surface. We break up the biofilm. The biofilm is much more resistant than planktonic bacteria. So it's 1,000 times more resistant. So if you don't break up your biofilm or remove your biofilm, you're not going to get rid of the bugs. So we killed all the bugs. And we hopefully can get something like this. So we hopefully can get a healing like this. Bone, we get vertical bone growth. We get vertical bone closure there. I love it. It doesn't always work. I'll say it doesn't always work because the patient has to be a sign on board for this lot. If you do these treatments and then they come back in a few days just to check on them, and then there's pieces of chicken, and you know how it goes with the plaque all over the place. They're not brushing. So before I start any of these things, we first have to get oral hygiene regime 100%, because otherwise, and the patient needs to come on board with them, otherwise it doesn't work. All right, that's perio, just basically. Endodontics, and this is where every endo I use my dual wavelength. I use 2 different lasers every time, and the evidence is there that it makes a huge difference. So bacteria can invade, as you can see, up to 1,000 micron into the dentinal tubuli. So once you've got, and normally, initially, it's multicultural. So there's lots of different types of bacteria that invade, but invariably on a retreatment, it'll be monoculture. So it'll normally be Enterococcus faecalis, because he's a nasty little critter, and he can withstand a lot of punishment. He can sit in there for almost a year, dormant, and be reactivated by some stimulus. So unless you get it out with lasers. But that's why endos fail a year later, and you got to understand why, because you haven't got all the bugs out. So if you had to take a warmed 6% sodium hypochlorite, agitate it for 30 minutes, you'd get 309 micron penetration. And none of us do that. None of us warm it and we sit there for 30 minutes agitating sodium hypochlorite. So we're not getting 300 micron. We're going to get much less. When you consider that your bacteria are sitting deep in your dentinal tubuli, there's a problem. There's a mismatch there somewhere, which makes it that 30 to 40% of your root system evades chemomechanical instrumentation. Also, we normally like to go down if it's only doing that, we think that canals are all round, the old days. Canals are round, and that it's very easy just to wash them out and we've killed all the bugs. But it's not like that. I'm just going to put this little 74% up to 500 micron. We can get out with using two lasers rather. So we think that canals are uniform in shape and it's very easy, but that's far from the truth. And how do we get all that debris? How do we get all this tissue out of here? And it's very difficult to agitate, to believe that we're going to get 100% or 80% even of that debris and of those bacteria out of there. It's very, very difficult to believe. Even with lasers, it's difficult to believe, but it's far easier to penetrate down in between those isthmusi, and to get down all those canals. I haven't got the slide on here, but I've got an example of a slide that I thought it was a 5. It had one canal. I did the endo. It was bang in the center. It looked like a great endo before my microscope. And I lasered it and I cleaned it out and everything, and I filled it. And the next minute I see there's another canal right next to it, but it's filled completely. So the laser action had actually cleaned out the adjacent canal, which went right from the tip and to about a couple of mils down from the original canal. So that's why it's the penetration for me and the amount of debris it can get out is unbelievable. As I said, it vaporizes bacteria. Those water molecules have that photoacoustic effect, and the smear layer, those water molecules expanding and contracting all the time, that cavitation cleans off. Those little microjets that shoot out will clean the surface of the central canals and penetrate even down the isthmuses, etc. So this is smear layer after mechanical instrumentation. That's what it looks like. Then over here, we have a smear layer after 17% EDTA for 60 seconds. And then using EDTA as well, using an erbium laser, this is what it looks like. And that's quite amazing as far as I think. The other thing it does is it removes the vapor lock, because often we squirt down medication and there's a bubble at vapor lock, there's a bubble of air at the bottom, and we're scared to go down deeper, and we end up with this bubble that doesn't do anything down there. So the laser helps with that. And also I found that if you put the laser in the coronal third and we activate it, then we actually you can clean a canal, and then we start doing this, and then suddenly I get some bleeding because it decompresses the apical lesion. So if there's an apical lesion, it removes it or decompresses anyway. And very few patients have pain after using lasers on them if I clean properly. So I get length, I use dual laser and send them home. And they don't ever have, well, they're not ever, but they have very little pain post-op sensitivity. The second laser is in endo is the diode laser. We discussed earlier that it has an affinity to pigmented tissues, hemoglobin and melanin, and also bacteria pigmented. We have transmission. Remember one of the first four, we wanted that transmission, and it's not absorbed by water or hydroxyapatite. So its first encounter of any pigment that it encounters is bacteria. So it kills them. I said, remember, we can get 74% of bacteria up to 500 micron. I did my thesis on this, and my thesis indicated that I could penetrate much further than that. I can get 1,000, but with about 60% at 1,000. Also, remember I said transmission, and we do photobiomodulation or low-level laser therapy. That's what it has that effect as well, and that might be partially to why we don't get sensitivity afterwards. I still use my diode laser separately for photobiomodulation on the apex of the tooth. So that helps the patients a lot. It helps with healing. It speeds up healing, but I'm coming to that a bit later. So we get this kind of thing. You get this kind of clearing out, which I found amazing. Lateral canals. It's amazing. This little thing in there, there's lots of that. And I'm not saying all my endos are like this, but I try and get that. I never got this kind of thing before in my endos. So I'm very happy with that. Although a puff is not the instrument of a measurement of a good endo. Okay, so now we can use the diode laser or the erbium laser on soft tissue. Sorry. One of my best uses is homeostasis. Post-extraction, put it in, I clean out the socket, I put it in on that blood clot, and I can turn the blood clot into a jelly baby almost. You put it on there and you puddle your laser into that, and you end up getting that clot organized. Because one of the biggest problems we have is that people wash out their blood clots, and then we have a dry socket. On that note, we can use it for dry socket as well. Erbium laser, we can clean all the bacteria out. We can institute bleeding again with the erbium laser, and then we can clot it again with a diode laser. We cannot use the diode laser on bone. That's a kind of a big no-no. So don't grab if you got one at work and you want to go do this, you can puddle it in a blood clot, but you can't use it on bone. You can't cut bone with a diode laser. There's nothing to cut. It'll just burn it. You'll get necrosis. But you can use an erbium laser, and it cuts beautifully and very safely because the absorption is so high in the water. There's very little penetration. So you can't hurt anything. You can't, as long as you got water, it's water mediated. So the laser has a water spray on it. As long as you're spraying water, you can't really mess it up. You can't mess it up. It's very difficult. So that's just cutting bone. I was talking about sulcular debridement in the perio. We can clean out all the granulation tissue. Gingivectomies, I use that all the time. Frenectomies I'll get to. Implant recovery, if you've got a buried implant, this is the nicest thing, is you just puddle it over the top, the erbium laser. You can use a diode laser, but not on the bone or on the implant cover screw. But you can open it up beautifully with an erbium laser, and the tissue stays where it is. So you can chop it away. It's so friendly to the tissue. The tissue loves it. And you can take your impression straight away. There's no bleeding. And I use also the same technique for crown troughing. Biopsies, I never used to. I'd be too scared to take anything off up until I started with lasers. And now I kind of chop off a lot of things. On a note of that, I always send it to the lab. Bacterial reduction in the pockets. If you're going to use especially starting out, I would kind of get a diode laser, and we use it for laser bacterial reduction. And you can use that, your oral hygienist can use that before scaling, and it reduces the bacterial load in that pocket, and hence less bacteria going into your bloodstream, which is a big risk in cleaning deep scaling. And then the de-epithelialization, which I said on the perio pockets, we de-epithelialize the top of the gingiva on the crest so that it doesn't grow down into the pocket, and we give chance for the connective tissue to catch up. Okay, this is one of my almost a practice boulder, ulcers and herpes, and I get people now who kind of know when it's coming. They get that prodromal effect, and they come running in and say, "Oh, just over here, I've got one starting over here." And before it gets to the vesicle phase, they can feel it, and I can reduce the response of that ulcer or the herpes. I can take that way down to a fact that it might not even occur. And what happens is that if you have one already, it reduces the pain. The light energy is absorbed into the tissue, and I'll get to that in photobiomodulation, but basically it turbocharges healing up to 6 times faster than regular healing. And as I say, they get it in the prodromal stage, they come running in, and I do it for them, and it kind of stops that missile crisis from happening. The settings aren't important at this stage. So this is what it looks like. You have something like this that's starting, well, kind of started, the vesicle's already there, and this is what it looks like. Uninitiated, remember that the energy can come straight out, straight into the tissues, and remember the 940 penetrates into the tissues. So it goes right down into the cells, and it will kill the virus that's in there, and B, it initiates healing. So you end up something like this. A guy pre-op pain, 7 out of 10. You'll know that this can get higher because they're very sore for these people. And then I used 2 different lasers here. You can see here, I used this frosted appearance. I used my erbium laser, but with no water. So I wanted to kind of crusts that area. So it stops that weepiness. And then I use the diode laser as well. This is the photobiomodulation, or low-level laser therapy is the old term, and it enhances healing. So we end up after one day it looking like this. Still a little bit of fibrin layer over there, but you can see that looks much drier and no pain, or very little pain. How's my time? We're doing okay. I must move it a bit. Okay, fibroma. You remember I said I did biopsies. These are massive. I've got one lined up now for guys coming next week. This week. And I take my little pincer. I give a drop of local in there. There's my erbium laser, and I basically chop it off circumferentially. I go around the fibroma or the tumor, whatever it is, and you can do that with an erbium or with a diode because it's soft tissue. So we cut it off with either, but we always send out to the lab. I'll always send anything you cut off, you send to the lab. So that's after 4 days, again, nice fibrin layer forming there, and after 10 days, Gonski. In fact, I use them often for pericoronitis while I'm on the slide. I can cut this away very comfortably instead of having to take the 8 out. A lot of people use a scalpel and do a wedge resection here and suture it. Excuse me. You can just actually take the laser and you just cut it away. And no sutures, no, and it'll just heal up like that. All right, so then, I don't know if you see this, but I see a few of these, normally on the lip, not quite as pronounced as this, but hemangioma. This lady, I kind of begged her that I could do this. It was just sitting there, and it was like going for a long ride, and there's a cold beer, and you can't get to it. It was sitting there every time she came to me, and I said, please, can't I just play with that thing? And eventually she said, okay, it doesn't look, my son said it looks horrible. So I said, I can fix it for you and it's not going to be sore. Anyway, so I did this, a tiny bit of local. I'm not even sure I used local, actually. I think it's topical on here. And I'm not touching it. It's an uninitiated tip. So all the energy is coming out the tip. And what's the first thing it likes? Pigmented tissue. So what's hemoglobin? Oxyhemoglobin. And those blood vessels there, you ablate them. And it causes, because the energy gets absorbed there, and it causes them to shut down. And that's what it looked like. I think that's probably about 2 weeks later. Then frenectomies. And I never knew what a frenectomy was really until I started lasers. Well, I knew what it was, but I hardly recognized any of them. And I think I sent 2 away in my whole career, which was like 20 years plus. Yeah, 25 years. I never sent 2 away because those are the only ones I saw. Now I see them all the time. And you don't know what you don't know. So I do stacks of them. So this is a couple of twins. And I did a kind of a split twin with the 2 different types of lasers. And I used an erbium here. And because it likes water, I cut it over here. And you can see how it loves the tissue. Remember, I was telling you, uncovering an implant, how good the tissue looks. This tissue looks brilliant. In fact, I do that laser bandage. Remember the crusting I told you about on the herpes? I do a bit of crusting on there to delay healing because it actually heals up too quickly. And you can have to do a revision. This one's a diode. And now I'm going to use the initiated tip. I'm going to block the energy from going out the tip. And I'm going to create a little bit of a hot tip. We're still getting all the effects of the laser, but we've got a little bit of a hot tip. And I can cut that tongue tie. And you can see how beautiful that is, a little bit more heat. But sometimes in these cases, I actually want it. And nowadays, I'm kind of opting for the diode laser because it gives a little bit more heat and delays healing slightly, which sounds counterintuitive, but we actually want it to be delayed slightly. I give them some exercises to do, and normally I don't have a problem. So now I've started doing it, I've been doing it for a while, on babies. This little Oki is like 5 days old. And the mothers come in there, they're distraught, they haven't slept, their baby's screaming, they have been to a lactation consultant, and they can't breastfeed properly. The baby's sucking air, or it actually can't just get the milk out the breast, and because of a tongue tie, or it's sucking air because of a lip tie, in basic terms. And if I release that, there's the lip tie, that the lip can now flare over the breast, and the tongue tie, the tongue can actually lift up and manipulate the nipple properly, and the baby can feed. And these ladies that come in they're almost in tears afterwards. They feel the difference immediately. And so it's really a great thing to do, a little nerve-wracking on a 5-day-old baby, but still, it's actually very quick. It takes 10 seconds and it's done once you're in position. Right. For the ortho guys who like ortho, this was referred to me by some other guy, a dentist, and he asked me just to uncover these. This is immediate post-op. As I did it, you just pop them open. I sent it back like this. The tooth like that, he can place his buttons. No hassle, no surgery, no scalpels, no, that's it. And I mean, I give local, but you don't really even have to give local in a case like this. You could be able to ablate it with a bit of topical, but I give local. It's much easier. No need to stress. Okay, then I do this. These are very common in my practice. I often see these teeth that just don't want to come out. It's not essential at this stage, but this was getting quite blue. Yeah, you can't really, the picture doesn't justify it. But, and at the same time, I did a lip tie and I cut it up. And it looks pretty gross when you look at it like this. You think, hell, that's a massive wound. But that's it. You cut it and there's no sutures. And the patient goes home like that. I give them a little cocktail that I developed that they have to do exercise with. It numbs it up a bit, and they do exercises. And it's fine. It's like a massive ulcer. So it's a bit tetchy for a day or two. It's a dental euphemism for sore. Tetchy for a day or two, and then it's fine. I also do, if they live close, I ask them to come in and I can do photobiomodulation, which speeds up healing. So this really helps. And the kids, I do lots of these. And, you know, this little 6-year-old, 7-year-old is not, they're not the easiest to work on. And I can still get this right. Then also referred by, for ortho, I don't do ortho really. And you can see this guy's, his oral hygiene is really swak. So I first try and get these guys to look at, I show them a mirror, I show them that they need to get their oral hygiene right. And then I can relieve their hyperplasia. And then this is what it looks like post-op 6 days. But you can see his oral hygiene is rubbish. I did the top then as well. But his oral hygiene was actually rubbish. But still, he now can at least clean. I'll explain where he must clean, and at least he can clean properly then. Okay, this is just a depigmentation case. I'm going to move a bit quicker of what we can do. I see 1 or 2 patients like this. In Cape Town, it's not really an issue. But this is what you do. You give it a little bit of local and mainly erbium, I would say. You can do it with a diode, but the effects are not as good. It's a bit more complicated with a diode, but with the erbium, it's really easy. And that's what you end up with. The patients are always happy with that. Hard tissues. Okay, so we've got for bone. Now we can't use the diode anymore here because it is not absorbed by anything in bone. So it's a pigmented thing. So we use erbium, absorbed by water. We can do crown lengthening. This is great for the GP because ordinarily, if you're doing a crown and you've got a distal box that's you're trying to put in a matrix band, you're gonna violate the biological width in that area. You can actually do a little crown lengthening with your laser straight away. Right then, it takes 3 minutes, 5 minutes, and you've done a crown lengthening. If you've got a crown and the border's broken, often you get these cusps that are breaking off, and they break just subgingival. You can do a crown lengthening. Take a little bit of bone, slide your laser down, take a little bit of the bone away to 3 millimeters from your gingival height, and you can carry on. You can do troughing, and you can carry on with your crown straight away. Apicectomies, not my story, but you can do apicectomy start to finish with the erbium laser, all the way from the incision, cutting the root tip, taking out the granulation tissue. Everything is done with the erbium laser. Sinus window, really out of my ball game. I don't do sinus windows. I know Howard does it. I think that's probably why he bought a laser in the first place, is to open lateral sinus windows. And you can do it specifically. We can take the shell off an egg without disturbing the membrane. So that's how you can do the settings. Teeth, we can do cavity preps. I use this all the time for class 5s. And then obviously endo, I've been telling you a little bit about endo, the smear layer, killing the bacteria. Veneer removal, that's fantastic. If you've messed up a veneer or you need to get veneers off, you can use the erbium laser because it attacks, there's nothing in the crown itself that it's interested in, but it loves water. So where's the first water is in the cement. So it targets the cement that's holding the veneer or crown on, and you just paint over the whole area, and eventually you can just tuck it off. Some of them pop off easily. Some of them a little bit more difficult. I had a crown that I always fit the crown, I hold it in position, lift it up, put the cement in, put it straight back again, so I don't move positions. And for some reason, there must have been a granule in the cement, and I cemented the crown, the guy bites closed, and punk, and there it is. It's got like this massive, you can't touch. So I quickly took my laser, I ablated all around, and I popped the crown off, cleaned it up, put it back again, all in 10 minutes. So that was it saved the day. I sometimes get referrals to remove veneers, and mostly they work well. If you got, not in veneers, but if you got a glass or enema, there's no water, it's dried up. So it's a bit difficult you can't target anything there. Periimplantitis, you can clean around implants. I normally refer these out to another practitioner with lasers. But you can clean right down there. In fact, they've got a laser tip that's kind of like a periscope. So it shoots out at 90 degrees. So you can slide it right down, and you can clean between the grooves of the teeth. So this is what you get, something like this, all this caries. And the bleeding here is not from the laser. This is from polishing there afterwards. You can see, look what that tissue looks like there. After chopping it away, you can see, you try this with a burr, that's going to bleed forever. Here's another example. Look at this tissue over here, and look what you can get. That's a dry environment down there. You can clean that beautifully. I use a matrix, a cervical matrix, a clear cervical matrix by Veneer. They're very nice. It's like a little cup, and you can slide it over the tooth, and you can seal it like that. And then you fill it and close it over, and you get such a nice finish. There's hardly any gingival finishing that you have to do. Also using the lasers, you can do laser anesthesia. So here's a little girl, and she was petrified, and she wasn't having an injection. And I said to her, I can play with a hand with a laser. And I said, I'm just going to put this on your tooth. And I could slowly increase the power as I went along. It sprayed water, and I could prepare that cavity without any anesthesia. And she was quite happy about it. I did a torus removal quite recently. This guy from the top and the bottom, and you flick it off. And I've actually done a few of them on him. That worked very nicely. Then lasers for whitening. This is true laser whitening. And we activate 38% a gel, but it's a specific, it has a pigment in it that absorbs the laser wavelength. There's very little pulpal temperature increase, but we do get a desensitizing effect on the nerve. And this is where that photobiomodulation or low-level laser therapy comes in. It's a kind of a window that you can use. So at this window, we actually give a little bit more energy, and it inhibits the nerve transmission. And so you don't get any, or you do, but you get very little sensitivity afterwards, much less sensitivity. The patients are very happy with using laser activation of the laser gel. Then I've been going on and on about photobiomodulation. And this is amazing for me. And the patients call it the magic wand. I still think of it as a magic wand. And it's kind of just, you don't know what's happening. It's difficult to know what's happening because less is more in this case. So, when people don't believe light can cure, but, these infrared lamps that you put on, we convert our light into electrical signals. Vitamin D synthesis uses light. So I was talking about in the beginning, the chromophores, the photoreceptors, the water for erbium, and the hydroxyapatite for erbium, and the pigment, etc. And there's a specific chromophore called cytochrome C oxidase in mitochondria that absorbs red light or infrared light. And what it does is it kicks off the nitric oxide that any stress cell has a problem with it bonding with oxygen. The nitric oxide blocks it. And what it does is it kicks off that nitric oxide, which is a vasodilator. So it increases vasodilation to the tissues, helps with healing. And it allows oxygen to bind again, and the cell in the mitochondria to produce energy, ATP, which helps with healing. And then it also helps with transmission to the nuclei. So by doing that, any cell that's inhibited will be put into normal function. It's like a jet engine turbine not being able to turn, and then you kind of spray it out and off it goes. So I'm nearly at the end of it. I should just make it. So the aim is to give 5 joules. I don't want to go into all the physics now, per square centimeters. So all we do is we set the laser at 0.5 watt on that little tip, and make it 1 square centimeter, more or less, circular centimeter. And we go for 10 seconds on the surface. And that's all you need, 10 seconds. For healing up those ulcers, if the guy comes in afterwards, then I'll just 10 seconds on it, and off he goes. He comes back a day later or 2 days later, I'll do it again, just 10 seconds. Increase the time because I want it to get deeper and penetrate more, because I want this dose at the target tissue, which might be deeper. So I'll do it for longer. And what we use is that bleaching hand fleeces, that big one you saw previously, and that gives me a bigger surface area. So I don't have to go 1, 1, 1, 1. I can just do it all in one go. And I use them for TMJ treatment. They work fantastically. Post-extraction helps, post-endo helps. But I'm really passionate about this low-level laser therapy, in case you didn't notice. Here's a case that I didn't do, but my mate, I think it was Jacques, went up. He was doing an outreach program, which I went up afterwards with. And this guy got bitten by a spider, and it was completely buggered. They're going to chop off his this area. They're going to amputate the hand. They couldn't get it right. This is like that antiseptic powder, Cicatrin or something. And they used the laser, and that's 4 treatments, 1, 2, 3, 4. And that was by the end of the weekend, the long weekend, that's what it looked like. From there to there, this is a few months later. But the guy kept his hand, and that's the power of a laser. Other little things that I use the laser for is, yes, this guy said, can you do anything with this nevus? I'm not a dermatologist. I don't really go for these things. I just thought I'd put it in. And all I did is I took my erbium laser, very little penetration, and I just kind of like scraped it off, if you want to know. I like filleted it out along the surface. And that's immediate post-op. It's like a depigmentation. And 1 day, 1 week, 2 weeks. And that's what it does. And then the other thing I do is fractional handpiece, is resurfacing of the skin of the face. This connects to my laser, my erbium laser, and it kind of like holotines a green if you play golf. That's what it does. It creates little light holes, and it makes tiny little light holes, 10 at a time. And as you just run along the skin, and it kind of like plucks out a tiny little microscopic section of the skin, and then allows all the collagen to form again, and it gives skin tightening. And that works very nicely. And I think it was a good timing, because I like this. You got to keep moving, especially for the young dentists. Don't be scared. Kind of go for it, because I started this whole journey. I was a regular dentist who just went about my business, did my things. And then I started getting involved with technology at about 55 when I did lasers. I'm now 61. And since then, I've got CBCT, I've got scanners, a microscope. I've really invested in technology. Don't be scared to do it, and you need to do it, because that's now where we are. It's now becoming the gold standard, I think. Thank you very much.
Hey, thank you for that insightful lecture. Before we get to some of the questions that the audience did ask, I have a question myself, and I know I'll forget to ask if I don't ask now. The biggest barrier for entry, of course, being part of the young dentists and being a young dentist myself, is one, the cost, and two, finding a use for it. So you've shown a lot of uses for lasers in general, but say now I could only afford to buy one piece of equipment in the laser variety. Would you think it's still good to start with the diodes, being a lower cost barrier to entry, or would you say to have the erbium laser, which has more uses?
I think a good starting point, especially from a cost perspective, is to get into lasers by doing a diode laser. And I think important part in that is to find a supplier that backs you, that trains you, that is there when something goes wrong, or can hold your hand. And I think that's very important, because a lot of guys can buy one off China or whatever, and you don't know how to use it. And there are plenty of uses for a diode. As you saw how passionate I am about the low-level laser therapy, and you can use it for all your surgical procedures, your frenectomies, your gingivectomies, your crown troughing, all that stuff. You just can't touch bone with it. So there are thousands of uses for it. So I would definitely start with a reliable, fully backed diode laser.
So also, just to maybe summarize and say as a follow-up, so if you're getting into the more advanced procedures or into dentistry in general in a private practice or in your clinic, and you can get your hands on a diode laser, I don't think you'd be touching bone anyway. So I think it would probably still have many uses, and I think we can learn a lot and do a lot more for the patient at a lower cost of entry.
Absolutely. And look, coming with when buying one of the machines is the training. You get fully trained. You need to know what's going on. So the reps that I bought my lasers off, I went to stacks of training things, and they came to me. They held my hand on a couple of my first cases. So there's definitely, I would emphasize, is that you need the backup and the training to do it. You can't just buy a laser and off you go. You can hurt a patient. So it's not very difficult. I know it sounds daunting, but it's actually very simple to use. And if you just follow common sense, you can't really hurt anyone.
Perfect, thank you. We're going to switch over to some of the questions that did pop up in the Q&A box. Just let me know if my signal drops. I just got a warning from Zoom saying my signal is unstable. So just let me know if I cut off. The first question we have is, do you still go through the protocol with the sequence of the different rotary reamers when you're using laser? And it's a two-part question. And the second part is, do you think they will reach a point where in endodontics where we can able to clean the canals with just the laser and no rotary instruments?
Okay, that's quite an interesting question. Having a laser does not negate the fact that you follow basic principles in endodontics or in periodontics. You still have to, I still use all my reamers to get to length, open up the canal, but I don't really have to open it up too much as long as I can get my 200 micron tip down to the apex, to 1 millimeter from the apex. That's good enough for me. If I can get that loosely fitting, then I can clean the rest with my laser. But you do have to establish length. You do have to use your reamers correctly. And I know that everybody knows Buller. At one stage, he was doing some studies and was cleaning canals with just saline and nothing else, and getting good results. But eventually, I think he can correct me if he wants, but I think the ultimate is not to throw that away. These other methods have been tried and tested. So why not use everything? I just throw everything, including the kitchen sink, at endo. It's such a volatile environment there. So you want to clean as much as you can. In saying that, you can clean with just saline. The lasers will do the work, but I just throw everything at it. I use all the medications, all the irrigants, and then I finish off with lasers, dual wavelength lasers. So the short answer is you follow normal protocol and you add your lasers to it.
Perfect. So the second question we have is, are there any specific dental treatment codes that can be charged for lasers in practice?
Okay, it's a little bit of a gray area. And there is a code which we use. I don't know if it's covered by medical aid. It's a 9099, which is a code for an unspecific procedure. There isn't a specific laser code, as far as I'm aware of, yet. But there wasn't one a little while ago for using CEREC either. So as the market will put pressure on medical aids, I think this will be a reality, that there will be separate laser codes because of the benefit that you're going to give to patients.
Amazing. I think the next one was answered in part, but I think I'll ask it anyway. Do you routinely use local anesthesia when using lasers?
It's not a routine. A lot of the procedures I can do is without local anesthetic. I know the advertising blurbs all say no shot, no this. I like to work comfortably. I like my patients to be comfortable. If I can give a painless injection, or if I can put a bit of local in, it just makes your life easier, especially when you're starting out. It makes it easier for you and the patient. My very first frenectomy, tongue tie, I did on I think it was a 6-year-old without local anesthetic. And the poor guy was like, I was still learning what to do, and he was squirming a little bit. So why put yourself through that? Just put a bit of drop. It only takes a drop, and you put a bit of local there, make everybody's life easier. On the subject actually of the codes, don't forget that you're now charging codes that you never charged before. So you're charging a frenectomy code, you're charging a gingivectomy code, you're charging all these codes that you never really used before. So that's where I kind of justify the value that you're getting back of laser. I don't even charge laser. I just use it because I'm using a code. I think you've disappeared.
Dr. Sher, it seems like Dr. Van Mark's, it's not going well on his side. You're welcome to check the Q&A and just answer the questions from there.
Okay, let me go find it.
Just at the bottom, to the left, I think it's question 4.
There we go. Yeah, sorry, mine was closed down there. Just have to go through the sequence. We've done that. Specific treatment code, we've done that. Do you routinely use anesthesia? Are the laser tips reusable? It's a funny question, but yes, they are reusable. If you're in America, they sell them as single use, the same as your files. Your endo files are single use, no? Not really. This is as we do reuse them, but you got to check your tips. You autoclave them, and you got to check your tips that they're not damaged in any way. They are quite expensive depending which ones you're going to use. But yes, they are reusable, and you do add that cost into into your treatment. Why the erbium for depigmentation when the diode is more pigment attracted? Yes, true. It is like that, but you don't want to once again go a little too deep. Where does your melanin sit? Your melanin sits quite near the basal layer, which is just above where the bone sits. So you can do it if you use a horizontal action on the gingiva, not 90 degrees, but kind of horizontal to the gingiva, and you slowly paint it away. It just takes a little bit longer. You can do it. It's a little bit more painstaking. I shouldn't put painstaking, it's a bit more lengthy. But an erbium is like, you just paint it off. It's really, really easy. So yeah, so I would, if you got a choice, obviously an erbium, but you can do depigmentations with a diode. And I've seen some great cases, not in my hands, but because I use erbium, but I've seen some great cases of using a diode for that, and they turn out fantastically. Okay. Next to me, I'm kind of just reading them here, Nate.
Yeah, don't worry. I'll take over. Sorry, my internet dropped there for a second.
Okay.
So essentially, the next one is about what the exercise that you recommend after doing frenectomies.
Yeah. So what I do is I take a little bit of Parox gel and a tiny bit of topical anesthetic, and I mix it up together, and I put in a little test tube, and I tell the patient to take for about 3 days. I tell them to take a little bit and put it under their tongue, and leave it for 30 seconds, and then to massage that area to give it a good, the Parax is antibacterial, to massage it, and the topical makes it a little bit numb, so they can actually put a bit of effort into it. Also to move your tongue around, pull your tongue into the back of your throat, like that, to stretch those fibers to stop them reattaching. But mainly using your finger. Also with the mothers, I'll just tell them after every feed, you can just use breast milk, and you can just rub. We don't put topical on babies ever. No topical, no local. You use breast milk, and you just rub it with her finger, every time she feeds, and that should take care of that.
Okay. And another one we do have is about, can the laser treatments manage TMJ pain, and can it provide a permanent solution for it?
Yes, the short answer is yes. Look, obviously there's a cause for the TMJ pain, and I think you need to address that. You need to check occlusion or non-contact interferences in your excursions, things like that. You got to see what's causing your TMJ pain. But once you've got this whole muscle mass that it's all in spasm, the laser works fantastically. And I'll give you a quick example of a patient I had, Herky. I use him in my lectures. He came to me and he had headaches every single day. And every day he had a headache. And I said, can I use my laser on you? No, that's rubbish. I don't do that stuff. I said, just let me use it on you. And I did one treatment on him, and I didn't see him for 6 months. And I bumped into him in the street, and I said, "How are your headaches?" He said, "Oh, I haven't had one since." So he comes annually, and I do a little bit of laser treatment. It takes me 5 minutes, and it just keeps everything relaxed. So I think the answer to that is yes, it is a permanent solution, but you need to find what the cause is. It's not a magic, it is a magic one, but not in that case.
Yes, I think otherwise it'll just mask symptoms or relieve some of the symptoms if you don't do it, and then it won't be a permanent fix, right?
Yeah.
Perfect.
But it works fantastically. The patients love it. They love that feeling, and they feel it immediately. A lot of them say, "You know what? I think I can feel it already," when they walk out. That's, I don't know, maybe.
Maybe I'll try it out one day as well.
Yeah.
The next question is about the laser whitening. What is the duration of the whitening process?
Okay, my hygienist does all the whitening, but basically it's much shorter. You do two sessions. You put the laser gel on. You can do more sessions if you want. You put the laser gel on, the same as you would do with any other laser gel. This has got pigment in it. You do, I think it's 30 seconds at 7 watts per quadrant. And then you leave it for 10 minutes, and then you wash it off, and you can repeat. And normally a whitening treatment, if we don't use laser, is about an hour and a half. This is under an hour. You can do it, and the results are good.
Okay. That's it. And next question is, how many different models of lasers have you had in your practice, and how long have you been using them for?
Okay, so basically I've been since, I think 2016, I've been using first started with a diode laser, and then I went straight, it wasn't much longer after that I bought my erbium. And I've basically been using those two because I support the company that I did do research on them, and the company that I chose gave me what I thought was a good training, and follow-up service. I mean, the first day I got my erbium laser, and these are expensive machines, there was something not quite working. I had one courier the next day down. It was in my surgery the next day, the red one that you see in my picture, and I had a blue one first, and they straight away couriered down and replaced it, just within a day. So that's the kind of service you need when something goes down. You want to carry on working. And it was just a little filter from the transport that had got blocked, but nothing dangerous. But yeah, so I have tried a couple of other lasers. I've tried a few others. You kind of know what you know what you're used to. You are who you're brought up to be. So I was kind of brought up with the lasers that I use, and they're good in my hands. Well, I feel comfortable with them in my hands. So, but there are other lasers, and they're very good lasers, and they also work. So, you just got to choose correctly and first be educated. As there are courses that are available, and you can learn about lasers. And if somebody wants to pop into my practice, not all, I don't know how many, 200 people, but you're welcome to come and ask me questions or come and look or whatever. I'm very open to that.
Okay, there is one last question. I'm actually not sure for which treatment they're referring to. The question is it about 30 seconds per quadrant times 4 times? I'm not too sure which question they are referring to, or which part of your...
That's a laser bleaching. Laser bleaching.
Okay.
Yeah, correct. Sorry. As I said, I don't do them anymore. Andrea does all of the bleaching, but quite correct.
Okay. Perfect. Right.
So
others? All the questions.
There's one here there was one here from Greta, double checking. So oral hygienists are allowed to use lasers. Very gray area in our scope as well. No, as far as I know, and I did give a lecture to the oral hygienists, that oral hygienists are allowed to use the diode lasers. I'm not sure about erbium, but you are allowed to use lasers with certain requirements. So my oral hygienist uses the laser for cleaning, for bleaching. You're allowed to use it for that. And you are allowed to use it for laser bacterial reduction. So an uninitiated tip in the pocket to reduce the bacterial load in that pocket before you scale and polish. And that just looks like all the questions.
Yeah, that looks like all of them. All right, thank you, Brian. On behalf of myself and the Young Dentist Council of SADA, I think it was a very informative lecture on probably one of the more misunderstood areas of dentistry. I know that when I think lasers, I think sci-fi. So I'm pretty sure I'm not alone. I hope I'm not alone in that way. But you shed some light, you know, it made it seem a lot less daunting. So I know for myself, I'm going to do a lot more research into it and start implementing it more in practice if I can get hold of one. So thank you so much. And I think unless there's anything else you want to close with, any take-home message, any words that are actionable to any of our viewers so that they can actually start using lasers or be getting more exposed to them before we cut off?
I think don't be scared of it at all, and reach out to the companies that will and ask them for demos and ask them to show you how they work. They're more than willing to come and show you how it works and what you can use it on. Maybe attend one or two of these little workshops. I think it's an hour of your time somewhere. I think they have them all over. All the laser companies have them in I think all the major centers. Just go and educate yourself on before you buy. Go and educate a little bit. Just go and listen to one of these little workshops or whatever, and play with it, and you'll see that you will like it, like I did.
Amazing. Thank you so much. I think that closes us off for the evening. And thanks everyone for joining. And if there are any other questions, I'm sure that you can reach through to SADA and they can give you Brian's details so that you can contact him as well. And maybe take him up on his offer about going to the practice and having a view.
Yeah. No problem. You're all welcome.
Thank you so much yet again.
All right, you guys. All right. Thanks for listening. And I don't know how many people are there, but thank you for your time for coming to listen to an old man in the young dentist with a young dentist.
Amazing. Thank you so much. Have a good evening.
Good night.
Thank you. I will close the session now.